Hello, everybody. Hi there. So welcome to our discussion of the latest news and abstract from ESMO, which is the European Cancer Congress, which took place this year in Barcelona. So we are here from patients today talking about the data about metastatic breast cancer. My name is Eva Schumacher-Wulff. I'm the chief editor and founder of the cancer magazines Mamma Mia. And I'm really, really happy that Professor Nadia Harbeck is here from the University Hospital in Munich. We discussed many congresses already, and I think we are a great team, and I'm really happy to have you here because you're so experienced, and I'm curious to see what our discussion will bring. So welcome, Professor Harbeck, and I think we can start with the first trial about hormone receptor positive tumors.
Thank you. It's my pleasure to discuss some of the abstracts from ESMO 2024. And the first trial I would like to show is the ABIGAIL trial. ABIGAIL is a trial that was done in patients with previously untreated advanced breast cancer, metastatic breast cancer, which is hormone receptor positive, and HER2 negative. And the tumor had to have at least one of the criteria for aggressive disease. That would be a metastasis in liver or lung, grade 3, which is very aggressive, looking under the microscope, or negative progesterone receptor, or blood value that sort of shows a tumor aggressiveness that is above the normal levels, or disease progression very shortly after starting the anti-hormonal therapy in the adjuvant setting. So 162 patients with these aggressive hormone receptor positive tumors were included, and they were randomized to abemaciclib, which is a CDK4/6 inhibitor with anti-hormonal therapy, or chemotherapy, and then followed by anti-hormonal therapy. So the primary endpoint, the first measure of activity, was the response to therapy after 12 weeks, either on the CDK4/6 inhibitor based therapy or with the chemotherapy. Here we see the two arms of the study again, and I think this is a very important measure because it shows how much tumor reduction each of these regimens can bring about. And then we also look at some side effects. So the primary endpoint again was the objective response rate at 12 weeks, and we see that with the CDK4/6 inhibitor, which is an anti-hormonal based therapy with endocrine therapy, letrozole or fulvestrant, 60% had a complete or partial response, and only 40% in the arm with chemotherapy. And if you look at stabilizations or of the disease, that would also be included. So here we see the results, the side effects after 12 weeks, and we can see that obviously there's differences between chemotherapy and the CDK4/6 inhibitor therapy. We do see that both make neutropenia, which is a lowering of white blood cells. But with the CDK4/6 inhibitor, we also know that that is not dangerous, because the side effect we're most afraid of is if patients get fever while they have only very few white blood cells, and that is very, very rare with an anti-hormonal therapy together with a CDK4/6 inhibitor. And then we can see that there's some chemotherapy specific side effects, like, for example, the neurotoxicity, which is this numbness in the fingers and the feet. Serious adverse events which are the dark colors, are fortunately very rare. So in conclusion, I think we can see from the efficacy results that CDK4/6 inhibitor together with anti-hormonal therapy is just as effective as mono chemotherapy. Even in the case of aggressive tumor disease, the response rates were even higher with the CDK4/6 inhibitor numerically, but obviously we now have to wait for the other endpoints, like how long the disease can stay controlled without progression of the disease, and that's why um, I would not say that this anti-hormonal therapy is necessarily better, but overall, since it's the same, has the same efficacy, but it has lower toxicities, and in our opinion can be taken for a longer time. I think this study just justifies what's written in our guidelines, that in hormone receptor positive disease, unless it is life-threatening metastasis, we should always try to go for a CDK4/6 inhibitor-based regimen and not resort to chemotherapy unless again, disease is life-threatening. So I think this study sort of nicely confirms what we've already been doing, what's written in our guidelines, and we have other studies like the Right Choice study that looked at this specific comparison in very young women. And all of these studies sort of show the same thing, that we think chemotherapy may be more effective, but actually the study shows it isn't, because the anti-hormonal therapy together with the CDK4/6 inhibitor is very well suited to control the disease.
Yeah, I think as you said, we've seen quite a lot of data showing that there's no disadvantage starting with CDK4/6 inhibitor in combination with anti-hormonal therapy. And you said life-threatening condition. So could you describe what you mean by that? What is a life-threatening situation in which you would say, I rather go for chemotherapy?
I think this is very rare, and in Germany we have good data that we use chemotherapy in less than 20% of the patients who come with the first sign of metastasis in this particular tumor biology. I think a good example is a patient that is very short of breath because there is metastasis in the lung, and patients are very, very uncomfortable. And we sort of have the feeling, if the first therapy doesn't help the patient, then the patient may not be able to receive a second line of therapy. Or if there, for example, the liver function is badly impaired, like there's alterations of the liver enzymes and also of the bilirubin, which is sort of the product of the liver functioning well. And if those values are all higher than normal, substantially higher than normal, that could mean that the liver is not working well anymore, and that maybe we do not have the chance to have a second line of therapy. And again, this would be an indication for chemo. But you can see that we have reduced the indications for chemo in patients who come with the first metastasis in this particular setting to very few indications. And we have good studies like the ABIGAIL study that even if the tumor shows signs of aggressiveness, CDK4/6 inhibitor is just as good as chemotherapy.
So in daily practice, usually in metastatic disease, if we have a therapy that is working, we always say never change a winning team, and we leave it as long as it works. So let's say we start with chemotherapy, like in this trial. Here it was changed after 12 weeks to the other combination therapy. Is this something you would do in daily practice as well when chemotherapy is still working? Because again, so far, we would say, we stay with the chemotherapy as long as it's working. They did different in the clinical trial. Doesn't it make sense to more often say, okay, disease is now under control, so we can change to the therapy that has maybe less or different adverse events?
So that's exactly what we do, that we sort of give the chemotherapy while it's still working, and we don't stop it fix after 12 weeks. If it's still working and the patient is able to tolerate it, we continue. But my experience says, for example, with the taxane like paclitaxel, that maybe after 18, 20, 24 weeks, we come to a time where there's either bothersome side effects, like we talked about the neuropathy before, or fatigue, or just patients are not comfortable anymore. And then we would stop the chemotherapy and say, well, it reached its maximum efficacy. Now we have to maintain what we have achieved. And for that, we would not necessarily combine with the CDK4/6 inhibitor, because there's again bone marrow toxicity, the blood cells need some time to recover, but we would just give an endocrine therapy like an aromatase inhibitor, like um, uh, fulvestrant, which is the injections into the muscle every month, and so just maintain the effects in patients with hormone receptor positive HER2 negative disease, but not give the chemotherapy forever. But having said that, we have patients who just respond to chemotherapy, don't want to have maintenance therapy. And so there is no optimal number. I think it's a discussion between us and the patients, and we'll find a way that the patient is comfortable and is ensured that we keep the efficacy and we maintain the efficacy for as long as possible.
And with this, the quality of life that patients, of course, have to report back to you, I guess, and then it's probably common decision of how to continue. And I think this differs a metastatic disease from early breast cancer, that you can be more flexible and concentrate more on quality of life, right? That's why it's so important for patients to report back how they feel, and if something is not going, to ask whether there are other options. And especially for the hormone receptor positive tumors, there were some new options now, or there are some new options that were approved recently. So I think you can really decide from various options what to do also after CDK4/6 inhibitor. But having said that, as CDK4/6 inhibitors, so there are different ones. So would you like always go according strictly to data, like which agent has brought which data in trials, or would you go according to adverse events, or how would you decide? Like now we talk about abemaciclib and there are others. So how would you decide, or would you trust that they all work similar?
So as you said, there are three of them. Abemaciclib that was used in this study. Then we have ribociclib that we're going to be talking about in a minute in another setting, and we have palbociclib. And the registration trials all were very similar with regard to delaying progression of the disease. We can say that we double the progression-free survival by using either of these three CDK4/6 inhibitors. The parameter where they differed a little in the registration trials, which was the secondary endpoint, so not something the trials were powered to show, is the overall survival. And here we have very convincing data for ribociclib throughout all the therapeutic setting. Abemaciclib has in the later lines significant overall survival benefit in the earlier line, and that shows you that also my answer why I don't think we should go by statistical significance alone. The difference between the two arms in the first line trial with abemaciclib is more than 1 year difference favoring abemaciclib, but given this the size of the study, it didn't reach statistical significance. So you tell me whether a difference of 1 year is significant or important for patients. So I think the answer is clear there. And palbociclib did not have a significant overall survival benefit in both of the trials, in the early line and the later lines. But if you look at the endocrine sensitive population, which is patients who have responded well to prior endocrine therapies, and there's also another trial called Parsival Long from our Spanish colleagues, where they just included patients with endocrine sensitive disease. The overall survival data are very similar to that of the other two drugs. So I don't like this sort of comparison just by statistical significance. We have it in our guidelines. So if anybody just wants to look at efficacy, they can find the recommendations in the guidelines. But I think in treating my patients, I would also like to discuss side effects. And I think there are side effects that are quite bothersome for patients. For example, abemaciclib can cause diarrhea, but it has less impact on the cells, so the neutropenia rates are lower, and ribociclib has some interaction with drugs that delay the signal in the heart. So there may be some disturbances in the heart rhythm, if particular if there's other medications. And palbociclib, we only need to check for the blood value, so it's actually the easiest to use, and that would be my preferred drug in endocrine sensitive disease for older patients who don't want to come as often. So you can see there's pros and cons for each one of them, and we discuss this with the patient and say we would recommend to take this drug or the other drug just because for this reason or the other reason. But efficacy is important, but we have to look at the overall picture as well.
And after all, I think clinical trials are difficult to compare anyway when the study groups or patient groups are so different and the design of the trial is different. So as you said, it's I think really important for you experts to discuss the trials and to give us recommendations according to our needs and the whole story and everything behind and the adverse events. And this is what I understood from shared decision making. And I think this is really important, especially in this case that you have different similar agents. We need someone to give a bit guidance, I think, to help us to decide together with you. So
Definitely,
now we
yes.
have another interesting trial about a tumor kind, which is hormone receptor positive and HER2 positive. So
Yeah, so we have the Detect 5 or Chivendo trial, which is actually a trial done in Germany and was presented by Professor Janni from Ulm University. So the study, as you said, is important for patients with metastatic breast cancer, hormone receptor positive and HER2 positive, and patients without any further treatment, but also with 1 or 2 lines of prior therapy, were randomized for chemotherapy plus anti-HER2 therapy, which is dual HER2 blockade, trastuzumab, pertuzumab, or anti-hormonal therapy together with these 2 antibodies. And sort of halfway in the study overall has about 260 patients. Halfway into the study, they amended the study. So everybody who had hormonal therapy or anti-hormonal therapy better also got a CDK4/6 inhibitor, which was ribociclib. So that's why the results are a bit difficult to explain, because we have patients that were treated just chemo versus anti-hormonal therapy together with the anti-HER2 therapy, and then we have patients who received, whenever they had anti-hormonal therapy, also ribociclib. So we have to look at these 2 comparisons separately. And the first one I would just like to look at is the comparison chemotherapy versus chemo regimen without chemotherapy, which would be the blue line. The red line is the chemotherapy containing regimen. On the left side, you find the progression-free survival. On the right side, the overall survival. And you can see very easily that there is no substantial difference between these 2 regimens. So whether I use chemo or I don't use chemo apparently doesn't give us an overall survival benefit in this setting. The side effects, I think, are interesting to see between chemo and no chemotherapy. You can see they're not that different, because the chemotherapies we use here are usually just one chemotherapy and together with the antibodies, and sometimes the antibodies cause the side effects. And the other thing is, as I showed before with when we discussed the ABIGAIL study, is also that endocrine therapy or CDK4/6 inhibitor therapy also cause side effects. The second finding, which is quite interesting, and I think we need to look at this a little bit closer, but also keep that in mind, because this was just the second interim analysis, so we want to see the final data as well, is that patients who received the CDK4/6 inhibitor did substantially better for progression-free survival as well as overall survival than those patients who didn't have the CDK4/6 inhibitor. So I think this shows that we have to discuss the use of CDK4/6 inhibitors also in the context of HER2-positive disease. We're not quite sure how to implement them, whether patients actually need them in the maintenance phase or whether they just need them if we want to replace chemotherapy. The study, as I said, is a bit difficult to interpret because half of the patients didn't have a CDK4/6 inhibitor, and that wasn't randomized. It was just by time. So the earlier patients didn't have one, the later patients did have one. So I think we need to have the final data to be sure how to interpret this. So that's why I have my conclusions for everyday clinical practice a little bit cautious. I just state that the combination of anti-HER2 therapy and anti-hormonal therapy can be an alternative to chemotherapy for some patients. We're not sure whether it's good for all patients. It also probably depends on the tumor burden and the age of the patients and the comorbidities. But we already have it in the guidelines as a alternative to chemotherapy in certain settings. And the question of whether we need to add a CDK4/6 inhibitor in this context, I think is something that we really need to evaluate further. We need the final data of the trial. We need to look at the publication in order to see who got what and whether these collectives are actually comparable. But I think it's a very interesting hypothesis generating trial, and obviously also we need to look at other data from international study groups before we change our guidelines accordingly.
What I hear in the patient community is that those patients with these so-called triple positive tumors, I think you don't really like this word, you told me once, but anyway, which means that it's hormone receptor positive and HER2 positive, they sit somehow in between the chairs because they hear from the patients with hormone receptor positive tumors how they've been treated, and the HER2 positive patients are treated different. So then they don't understand why, if they get chemotherapy, they don't get endocrine anti-hormonal therapy at the same time. So could you maybe just summarize again how these patients with metastatic triple positive disease are being treated according to our guidelines today?
Yeah. So maybe first why I don't like the terminology. We've used it very early, couple of years ago already in some of our trials, but it's a very sloppy terminology because also a tumor that has only one hormone receptor positive would be a hormone receptor positive, HER2 positive tumor. So only if the estrogen receptor is positive. So not all of these tumors are triple positive. Some of them may just have two receptors that are positive, ER and HER2. That's why it's probably not the correct terminology, although it's a nice terminology because we all know what we are referring to. So that's having said that, and so far in our guidelines for the initial therapy in every line of disease, the hormone receptor doesn't play a decisive role in HER2 positive disease. We don't do something different in initiating therapies. We give chemotherapy with dual HER2 blockade in the first line setting. Second line setting is this new antibody drug conjugate TDXD, which would be administered without any endocrine therapy. And also in the third and fourth line, we would not use endocrine therapies. But what we would do is, for example, in the first line setting, let's say we start with the taxane plus the two antibodies, trastuzumab, pertuzumab, and then, like we discussed earlier with the first abstract, patient gets tired, doesn't want to have chemo anymore, maybe after 3 months, after 4 months, after 5 months, and then we decide to do a maintenance therapy, which is adding anti-hormonal therapy and just continuing with the antibodies. And that we can do forever. Like we have a patient, I think we started her in 2013. And now she's on endocrine therapy together with antibodies. So, but she's still in complete remission from her liver metastasis. So, this maintenance therapy can be done for a long time. Whether in the future we will not start with chemo, but start directly with, like, for example, CDK4/6 inhibitor, endocrine therapy, and antibodies, we have to see, because times are changing. We now have TDXD, this antibody drug conjugate, was very important, very effective. Next year, we will have data on TDXD in the first line setting. So when metastases come for the first time, we can give probably TDXD. And we know with these antibody drug conjugates that endocrine therapy doesn't make them more effective. On the contrary, if you block tumor cell proliferation, maybe these antibody drug conjugates don't work as well. So I think we have to be very careful with just adding endocrine therapy in this context. So things will change. Guidelines will probably change next year again. So I think we need to continue the discussion and see how we treat HER2-positive breast cancer, because there's a lot of options right now, and there's a lot of change due to new study results.
So this is a field with a lot of changes, as you said. So it's a good reason for us to visit the next congresses and to sit together and discuss again. So I want to thank you very much for your time. I hope that it was interesting for all of you out there. I hope you got interesting insights. We have another video of about HER2 positive and HER2 low and HER2 ultra low tumors. So just have a look, and I think we picked the most interesting trials, and we'll continue during the next congresses to see what might be important for you and praxis changing. And I'm looking forward to have further discussions. And thank you again very much, Professor Harbeck, for your time.
You're quite welcome. Thank you all for watching.